It says I'm live. How you all doing today? This is Choya. I'm glad to talk to you all today. Those of you all who are out watching, hello, social workers of Alabama. We've got some things as usual to talk about today, and I'm hoping my computer hangs in here with me because, yeah, this computer's been giving me some problems. I paid a lot of money for it. I don't really like that, but it's life. All right. So we got some things to share about supervision. How many out here doing supervision? How many out here are out there are scared to do supervision because you don't know what to talk about? You don't think you have the content to give. Well, I want to be able to continue to share with you what I have and so that you can have ideas and steal from what I have. As much as I can, I try to use after I shoot these videos, attach clips and just to give you ideas of what to bring into your supervision groups. But it's also very effective if you're into psychotherapy or if you're just helping clients in general. We talked a lot about suicide, and a lot of times that happens outside of psychotherapy and a number of other things. But this is somewhat based on supervision and things of that nature. And so today, what we plan to talk about, if I can find my title here, um, yeah, we want to talk about um, what do you do outside of talk therapy? What do you do outside of talk therapy when you are working with your clients, right? And so a lot of times we're working with our clients, we may anticipate that they have certain conditions like if you're working with a client and they tell you, "Man, I just can't remember things from my childhood." Oh boy, that's a sign of something, right? If you're working with a client and you start talking about something that seems somewhat traumatic and they're like, I just can't remember from there. Um, I can't tell you how many times that this has happened while working with clients. They can't remember things. And so one of the things that I've been doing lately, well, I'm going to tell you in a little bit. So I've got a tool I want to share with you that's helpful, and hopefully we'll definitely get to that. But I want to make sure that I get through everything in a timely way. So I better get on with the program here. But before I do that, I would like to share with you some of the things that we have coming up. And one of the things is we just had a wonderful live training not too long ago, and we were able to have LB Brown come and speak to us and spoke about perinatal concerns in mental health, and that was an awesome topic. And we've got some other things coming up as well, and I will be posting as we go because we have another 1 hour CU coming up. But I want to share with you these in particular, and we're just going to spend a quick second on this. This is the DSM-5 TR training. This is something that is required for LICSWs. If you have an LICSW, you will be required to do a training, a DSM-5 training. We have this and it's self-paced. We got a really good price on that. And so if you want information, we should have it listed. And then we also have another training in November for those of you all who want to be social work supervisors. And we've been having an awesome group. We had an awesome group of people come through our training last time, and a lot of people are growing and learning in that area. That's in November 11th and 12th. If you have any questions, just DM me. And then we have a DSM-5 TR training that's coming up on next week on the 27th, Tuesday, and it's live. So if you want to get that required DSM-5 training, come and see us. That's next week, Tuesday. We hope to see you there. And I think that's it on announcements. All right, let's move on to some of because I got so much. Let me tell you, I got so much to go through, and we're not going to get to it all. I already know, but this is just like supervision. You want to plan to have more than what's needed so that you know, it's always better to have more than not enough. And what I do with each group, it's like some of my supervisees will be making up and have missed and will come maybe have to do two groups in 1 week. Um, so that would be 2 hours supervision a week. And so what they will do a lot of times is come into another group and they get a whole different presentation. That's because I'm basing what I present on the needs of that group, although I have a template. All right. And so what we talked about in this particular supervision session, it was a lot of stuff. I'm just going to scroll through and let you see a little bit of my notes. Um, and we just, of course, I can't show all this, but I just love to bring resources. This is a video that we're going to look at right now, but I brought up a question, start asking him. I gave him the answers, gave him a little, we talked about the answer to the question here, which is basically all of these. You can experience apathy, but wanted to make sure they're familiar with what apathy is. And I don't want to get too deep into that, but then we talked about how major depression would probably be the best answer, but you can experience it with all, and how bipolar has similarities to major depression. When you have manic depression, like manic depressive, it was called was it manic? I don't forgot the name. Manic depression, I believe, back in the day. But a part of that is that you go into a very depressed state, which is similar to depression. So you can experience apathy, and then schizophrenia, you can experience apathy. I asked the question, what is apathy in schizophrenia? Would that be considered a negative symptom or a positive symptom? And of course, the answer was negative, and then more positive would be like delusions, hallucination. Went through that, and I'm going fast, so I'm probably gonna say something stupid that makes sense. Just write it off, because sometimes I don't get it all right, but I try to get you the most. All right, and then for when we talked about bipolar, we always like to go through the mnemonic to remember these are all the signs and symptoms of a manic episode. Consistently asking them what encompasses a manic episode. Type that in the chat, what a manic episode is. What the symptoms of a manic, how long does a manic episode have to be present in order for it to meet criteria, and then showing them these videos. Just repetition deepens depression, but then we move on to other stuff. We even talked a little bit about the Greek with apathy, and apathy meaning without, meaning without, pathy meaning emotion or feeling, whatever it takes to get it glued in there. We talked about dissociative scales, if you want to, ways to concretely identify dissociation, we're going to talk about that. Interventions used to support dysregulation in clients. And then tools that, these are some of the interventions. Talked about that, and then we're going to get into this little thing here. I can't wait to talk about that. And so, so we're almost 10 minutes in. So let's get started. So, I want to show a video. In this video that we'll share, is one of the videos that I showed. I think I showed this one in all of the sessions. Our last session today, we got into another video that I had just come across, but it was relevant to a case that the one of the supervisees was experiencing. We actually spent half the session on those on that scenario. But let's see if we could bring up this video. And I want you to take a listen and tell me what you think about it. And I thought this was interesting. And so let's just play it. Okay. Yeah.
You move into dorsal vagal, which is when a lot of animals would play dead.
Let me just see if I could try to get that from the beginning. I just had it all set, and anyway, it didn't do what I wanted it to do. And that's the thing with Instagram, you can't make it go back. And so let's just let's do it this way real quick. Let's see. Stop. Okay. All right. Then let me see if I could get some sound, and then let's play. And I hope it's sharing.
You stay in fight or flight too long. You move into dorsal vagal, which is when a lot of animals would play dead. When the threat is too big, we play dead. And that for me is burnout. Mm-hmm. That is apathy, disconnection, dissociation. We are disengaged. We are literally like the Walking Dead. If you tell me some good news, I can't feel it. If you tell me bad news, I cannot feel it, because the body has gone into a very protective state, because it was in that chronic fight or flight for too long and it said, shut it down. This girl's going to lose something if we don't shut it down. So it shuts off the nervous system at that point, which is our ability to feel and connect with things. You can bring that back down into a sense of safety by what you create around you. It's really about, these kinds of shutting down the nervous system stimulation, basically. We are hyper-stimulated. And how do we turn off some of that stimulation? How do we connect to the breath? There are, physical exercises you can do, whether it's, giving yourself a hug, rubbing, cold things on your neck, meridians, stretches, yoga. But it also has a lot to do with our environment. An environment like this is very calming. When you stay in fight or flight.
So it's a lot I could say about that video. Because what she was talking about is kind of what happens when we get dysregulated, right? When we get dysregulated, there's a number of things that happen when we get dysregulated. And the goal, what we want to do is be able to help clients when to get back regulated, of course, if they experience dysregulation. Um, okay. And so part of this is when this dysregulation occurs. Let's just say that you have a client, they start talking about a situation, either that they experienced or they start talking about it in front of you. I remember having one client, they just start talking about a situation of trauma, and each time they would go into talking about trauma, their eyes would just rapidly move back and forth. And at that time, I didn't really even know how to help them to regulate in those situations. But their eyes would just move way back and really fast back and forth, and and things were changing inside of their body. They were becoming more tense and more dissociated. It's the same client that I was speaking to that just bust out and screamed so loud in my office, but it was actually therapeutic for them. Anyway, I don't want to get too much into that. But this is what happens sometimes, is that a client can get somewhat dysregulated, right? And so what do we do to calm them? Sometimes if they get dysregulated enough, it can happen even right in a session that, yeah, they can experience apathy. What is apathy? It ends up being like a loss of interest. And that's what we talked about too. What is apathy? What does that look like in real time with a client outside of the term apathy? What does it look like when a client loses feeling and emotion? Okay, so that might look like they don't participate in their normal routine. And we talked about this last week. They may not go grocery shopping the way that they used to, or just shopping in general. They may not work out just the way that they used to in general. So that's apathy. But the apathy, when it starts to lead to a disconnection, right? A disconnection, and that disconnection then leads to dissociation, and you're noticing or hearing from their history that, you know what, it looks like they can't remember pieces of childhood. It looks like that when we talk about certain things, it's almost like they daze out, almost like the lady that I showed in a video a few weeks ago, when her daughter started talking about her own trauma. When the mom started listening, it's like she was started to think about her own trauma, and then she was dazed for a second. You could just see the glare in the eyes, right? So what happens when someone gets dysregulated, and how do we prevent that? And how do we work with it? And then how do we look at diagnosis? We're not going to get to answer all of those questions, but one of the things I do want to answer is, like, if you're suspecting that a client that you're seeing is having some dissociative symptoms, then there are some tools that you can use. And one of them, ooh, I want to show you. Uh, okay, let's see. And I was supposed to have this up already. And that's the thing. What tools are you all using? Um, it's really interesting. And this is one that I'm starting to try to use, especially since doing the EMDR training, to use, because I deal with so many individuals with trauma. I'm starting to hand out the ACE. I'm starting to hand out this dissociative experiences scale. the GAD-7 and the PHQ-9. It's just really good to have these to empirically guide you. But some of you all may not be familiar with this scale. And so what I did in supervision was read a little bit of this out. And so you could spend a whole session basically talking about this. But I said, what scale? I didn't even mention it. What would you use to help you to concretely be able to more concretely be able to diagnose a dissociation? Or if you think that a client is dissociating, but you're not really sure, and you're like, oh, well, I don't want to, think that something's going on, and it's not. Okay, well, there's tools to help, and this is one that is very commonly used. And let's just go through the first question. So this scale might look weird. It says some people have the experience of driving or riding in a car or a bus or subway and suddenly realizing that they don't remember what has happened during all or part of the trip. Select a number to show what percentage of the time this happens to you. So is this happening to you no time at all? You've never experienced this 10% of the time, whatever. And so that's kind of how you use the scale. Some people find that sometimes they're listening to someone talk and then they suddenly realize that they did not hear part or all of what was being said. And then when I was learning about this skill, I started to think, well, maybe this is me, because that happens to me a lot. But I continue to read. It's not so much the case, because some of y'all experienced that too. You probably haven't heard a word I've said right now, right? So some people have the experience of finding themselves in a place and have no idea how they got there. That's got to be a strange feeling. It was another one. There was another one on here. Um, that I wanted to point out, but I can't remember. But so this is a skill that you can use to help to guide you. And if you look on the internet and things like that, it can help you to understand how to score it. And I use therapy notes, and therapy notes actually has this where you could send it to the client and it comes back already graded and everything. And it's just awesome. I didn't notice that was there for a long time. Okay, so what else? What else did we talk about? So the question was, one of the questions is, how do we then get the client regulated? And some of the things that I have been learning is that regulating a client doesn't just involve the psychotherapy. Regulating a client also involves some other things that we need to know. What are some other ways that you can think that you can help to regulate a client, even if you wasn't necessarily, well, let's just stick with the psychotherapy setting, right? What are some ways to help to regulate a client outside of talk therapy, not psychotherapy, but outside of talk therapy? And this is an important point, and this is something that I brought up, and I'm gonna continue to bring this to my groups, because I think that a lot of times in school we're just learning one way, and we don't recognize that we can tackle things in several different ways. And so sometimes many of us are not familiar with the body work. It's something that I'm learning. I think another name might be somatic interventions. And so these are things that, like I said, I use this one personally at home. And I've already forgotten the name, but if you get dysregulated, your client is having their impulses or anxiety is just going crazy, then you get this is part of the tap. They do this a lot in DBT, and it's temperature. Don't get me to trying to tell you that mnemonic, but definitely you use for what you're doing is using ice water to regulate the situation. So when you're dysregulated, a lot of times, like when we're doing Gottman therapy, the Gottmans suggest that you use O2 sensor type of thing. And sometimes those things, they have a little something on there that kind of lets you know how fast your heart rate is going with the O2 oximeter or whatever it's called, right? And so what happens is when you get upset and when you're dysregulated, many times your heart rate will go up and it'll go really fast, right? And so that when that thing goes up too fast and it starts beeping, that means that a lot has been going on in that session between the couple. Well, the grounding intervention that I just used, or the intervention, the technique that I just described, actually, when you put your face, immerse your face just that way, and I've talked about this, into that ice water, it actually pulls down the heart rate, and it calms you, and it works very well, almost like medication at that time. And this is something that I was told by someone who works in a DBT institution, and so they're doing all this these distress tolerance interventions. But you got the 5 4 3 2 1, you got deep breathing, and so these are things, progressive relaxation, that can be added to your interventions to help to calm, because see, they need to be able to be calm once they're outside of psychotherapy, because they're not going to be able to talk to you. What if they want to just go commit suicide, or I know we're not supposed. What if they want to harm themselves, right? Or something like that. Safe place, tapping, or emotional freedom techniques. Okay, body scan meditation. Okay, so these are some things. Soothing touch. There are other interventions that can be used, and so we talked about that. So quick way to learn. Most of us have heard of the 5 4 3 2 1, and that's what I want to get into real quick, and we're going to end on that because we're already at time. All right. So, for the life of me, I can't remember, or haven't been able to remember, um, what how to remember 5 4 3 2 1. I always hear people say it. Okay, so the idea is, if someone is dysregulated, they oh, or they're seeing trauma. It's like, oh, we want to, there's different ways you can get them stand up, start kicking their legs and arms, things like that. There's different things that you can do to get them calm, right? And the 5 4 3 2 1 is a technique that's commonly used to help to regulate the distress of the client, right? And so the thing is, if you want to do the 5 4 3 2 1, you have a sheet in front of you, and you might not want to, have your phone or whatever. How do you know what to do? All right. And so the thing is, some of you all are real smart, and you just memorize it off the top of your head. But I thought it would be helpful, because I think some of these techniques can be used to work with clients. I haven't figured that out just yet, especially with children and different things, and helping them to process things with uses of images, helping them to even memorize things. But I haven't figured that all out. But definitely, if you're trying to, if your brain works kind of funky like mine, and you just don't retain certain things in it, or you retain it in a weird way, and it's a lot that I'm learning too, is that trauma, and it even doesn't even have to be deep trauma like what I'm learning, not even like a significant trauma that but it could be experiences that you've had, that service trauma, that can cause you not to be able to um, identify or process things in the way that you should. Um, and it doesn't always have to be trauma, I don't believe, but what they're finding is that many times individuals who have autism, who have major depressive disorder, it was some others name that I don't want to just make up names here, but there's inflammation on the brain. And so there are things that are happening in people's lives that are many times causing the inflammation in their study. And sometimes that does involve trauma. But anyway, getting back to trying to just memorize stuff, okay, in order to calm, 5 4 3 2 1. So we see here, we have some big eyes. We're going to have to do this in 2 minutes. We have some big blue eyes right here. And so that's 5. So 5, you would say, I want you to think of 5 things that you can touch. Okay. Then I want you to think of 5 things that you can see, obviously. Okay. But see, I had the image. I was going to the next one. I was like, that doesn't make sense. So 5 things that you can see. And a lot of times, if you can't remember what the next one is and I created this on AI. So y'all let me know if you need to know about that. But I created this is free, and it wasn't exactly what I wanted, but it got the job done. And so I had this created. And so I'm following the 5, and I see that that's in the eyes. So 5 ways that you can see, obviously with the eyes. 4 ways that you can touch, because that's a hand. 3 ways that you can hear, because that's the ear. two ways that you can smell. We got a big nose right here on that too. And then one way that you can taste, because we have the tongue here on the mouth, right? And all you have to do, I learned these techniques through this guy. His name is Ivor, and he does this thing called phototheology. And I've been using these techniques to learn other things outside of the Bible, which has been very helpful for. But even my little 5-year-old is able to learn stuff like this now. So and quick with it, right? So again, one. Okay, let's start from the 5, right? So then you're talking to the client, and so you have these images in your head, and you're saying, what I want you to do, or you could just have a sheet of paper, pull it out. I can't keep up with all these papers I've got, right? I just need to be able to just do some stuff. So I need you to tell me 5 things that you can see in the room, 4 things that you can touch in the room, 3 things that you can hear in the room, uh, 2 things that you can smell in the room, 1 thing that you can taste in the room. And just going through this technique many times can help them to get regulated when they become upset, when they start talking about trauma and cannot calm. And these and other techniques like the tapping that was in there, other self-soothing techniques can help your clients work through traumatic situations. And talk therapy is not necessarily involved or needed at that time. Hope this has been helpful. We better end it here. Y'all have a great weekend. Bye-bye.